Good evening, everyone, and welcome to CureTalks. I am Shweta Mishra, your host, and today we are discussing hypothyroidism and Hashimoto's disease in relation to infertility and how functional medicine can help in its management. We have with us our eminent guests and experts, reproductive endocrinologist Dr. Amy of Egg Whisperer Enterprises and functional medicine expert Dr. Christine Marin. Dr. Christine Marin is an Institute for Functional Medicine certified practitioner who was introduced to functional medicine after struggling with pregnancy complications and recurrent miscarriages, and addressed her own underlying health associated with gut infection, hypothyroidism, and hormonal imbalance, and she cured it using functional medicine. Dr. Amy, also famously known as the Egg Whisperer, is one of America's most famous fertility doctors and has been very kind to spare her time to educate us at CureTalks since the past 4 years now. So Dr. Amy, thank you so much on behalf of all the CureTalks team to you. And I welcome you both, Dr. Amy, Dr. Marin, to CureTalks today. And on the patient panel, we have Michelle DeMarco Amato to guide the discussion from the perspective of a patient who dealt with both PCOS and hypothyroidism, along with other autoimmune diseases, and managed to lose 80 pounds of weight to control her symptoms. Welcome to CureTalks, Michelle. It's a pleasure to have you with us today, and we are excited to listen to your story and learn from your experiences.
Thank you so much for having me.
To the folks in the audience, if you're listening us live on YouTube, you can post your questions in the chat window and we will try our best to answer them. Or you can also post your questions on curetalks.com show page. So without further delay, I'll begin the discussion. We have a lot of good questions to answer and a lot of folks who are excited about this talk and looking forward to listen to it. So I'll start with you, Dr. Marin. I request you to begin with explaining about some of the reasons why hypothyroidism develops and how is it different from Hashimoto's thyroiditis in terms of clinical manifestation. What are additional symptoms, dietary restrictions, and lifestyle changes that the person should be more careful about if she has both Hashimoto's and hypothyroidism on her charts?
Yeah, sure. So hypothyroidism by definition is when TSH is outside of the reference range, it's higher, and free T4 is under the reference range or lower. And what that refers to is just TSH is really a regulatory hormone that comes from our brain to try and stimulate the thyroid gland, which is kind of at the base of our neck, to produce thyroid hormone. And thyroid hormone really regulates everything. Everything. It is sort of our basal metabolic gland. I mean, metabolism, sex hormones, all of these things are correlated with our thyroid gland. Regulation of the gut viscera, so like intestinal motility and those kind of things also rely on healthy hormone function. So thyroid hormone can be, or the thyroid gland rather, can be affected by an autoimmune condition called Hashimoto's. And Hashimoto's disease is the #1 cause of hypothyroidism in the United States. Now, not all women with Hashimoto's disease necessarily have poor thyroid function. In the very early stages, there can be this autoimmune disease, and Hashimoto's is characterized by either thyroid peroxidase or thyroglobulin antibodies that can be detected in the blood. Sometimes you'll also see changes on ultrasound of the thyroid, but when those autoantibodies are active for long enough, they eventually cause thyroid hormone or thyroid gland destruction, which decreases the output of thyroid hormone from the gland. Over time. Worldwide, the most common cause of hypothyroidism is actually iodine deficiency, but here in the United States, it's really Hashimoto's. So I think you asked about lifestyle solutions and sort of dietary interventions with both of those. And so it really depends. I mean, it depends on what the underlying cause is. For Hashimoto's, in terms of diet, I always recommend that people are gluten-free. And that's really based on research from a man called Alessio Fasano, who is an MD, kind of PhD researcher, who discovered this molecule called zonulin. And there's this big thyroid-gut connection that we'll probably touch on. But short answer is, if you have autoimmunity, I recommend a gluten-free diet. If it's not autoimmune in nature, so you have Hashimoto or you have hypothyroidism without Hashimoto's, not necessarily, you don't necessarily have to be gluten-free. I always encourage my patients to really limit refined carbs, limit sugar, limit artificial sweeteners, or just stay away from them. Try to get a really nutrient-dense diet, foods that are high in things like zinc and selenium and iron and vitamin B and vitamin A. Eat healthy fats. Generally, those come from nuts and seeds. avocado, olive oil, olives. Gut healing foods, it depends on the individual, but fermented foods can sometimes be helpful, and limiting alcohol. And with regards to lifestyle, I really focus a lot with my patients on adopting a low tox lifestyle. So I think part of the challenge with our thyroid is that we are up against a lot of toxins in our environment. And many of these toxins are particular offenders to our thyroid function and our sex hormones. They're called endocrine disruptors. And they're well known, even among endocrinologists, but they're pretty ubiquitous. And so some of the more common ones would be like fluoride and chlorine. Those are two types of halides that can displace iodine from the thyroid. So I always counsel my patients, especially those with hypothyroidism, to try to find a suitable replacement for fluoride. It's hydroxyapatite. I always recommend a toothpaste with hydroxyapatite instead of fluoride. Make sure to filter your water. You would like to filter out the chlorine and the fluoride. We also inhale a lot of that when we take showers, that kind of steamy water vapor. So, there's a lot, but like the basics are clean water, clean air, and clean food. Also heavy metals. So probably the most common source of heavy metals now are dental amalgams, which have mercury in them. And just recently, the FDA has actually recommended against these types of fillings in women who are either trying to conceive, pregnant, or breastfeeding. So that's super interesting because it's a newer kind of recommendation from the FDA, but one we've been talking about for a long time. And just in general, really thinking about good quality sleep, reducing stress, restorative exercises like yoga, meditation, spending time outside, professional therapy, counseling, all those things can be helpful. But generally, my biggest focus is really just helping people get rid of the toxins that they get exposed to every day.
Uh-huh. Okay. Thank you so much for that very great, clear explanation. And to your point of, heavy metals and dental amalgams, I do have a follow-up question for you. But at this point, I think I'll bring in Dr. Amy. And Dr. Amy, I would like to ask you to talk about how both of these conditions can affect a woman's fertility, and what advice would you give to a woman who is undergoing IVF, and after 20 long years of controlling the thyroid levels with medications and having a negative antibody test for the last 10 years, now tests positive for those antibodies. So basically now she's in the category of having Hashimoto's as well as hypothyroidism.
Right. So from a fertility standpoint, we know that normal thyroid function is really important to have a really healthy ovulation. So to find out if you have normal thyroid function, doing the simple test that Dr. Marin described to us, and I'm sure she's going to go into way more detail about them very soon, but it's part of my Tushy method. For those of you guys who don't know, you can go to tushymethod.com, and that's the H part of the hormones that I think everyone should do pre-conception. So that's looking at your thyroid function. When you have a pregnancy, the last thing you want to happen is to have a miscarriage. Of course, no one wants that. And then have someone find out that you had pretty severe hypothyroidism. And that's actually what happened to my mother. And that's why I became a fertility doctor. She had 3 miscarriages. Her TSH was over 100. You can imagine that I got pretty fired up.
Wow, that's a high level. I just had up till 10 and I was worried. And you said,
yeah.
Okay.
Yes.
Sorry. Go ahead.
And so medical family, you would think that someone should have picked that up. This was obviously a long, long time ago, but I've seen firsthand from family experiences how serious thyroid disorders are and how they can affect not just fertility in general, but also can cause miscarriage. So I'm not trying to scare people, but I'm just trying to say, we work so hard to get pregnant now as women are delaying childbearing. This is a very simple test that you can do, and I would take it seriously. If it's normal, that's great. You don't have to check it every day or every month. But if it's not, you have to have close follow-up. And if your doctor isn't paying attention to you, there are so many really, really wonderful medical endocrinologists that are just as passionate about, I don't know that they have Tushy methods or anything like that, but they're just as passionate about the thyroid, just like Dr. Marin is. And hopefully you can find someone like who will follow you in pregnancy. And as far as the clinical question that you asked, a woman who, after 20 long years of taking, thyroid hormone and has had negative antithyroid antibodies and now is positive, it is not unusual to see that. We do see that. I get less worried, though, if the thyroid function is completely normal. And I wouldn't delay treatment or delay pregnancy because of that, but I would make sure that I also, work with thyroid specialists hand in hand. We work together with our patients to make sure that I'm doing all the things I could possibly do for them. And so I would defer to the thyroid expert that I work with, but also make sure that the thyroid function is normal.
Okay, thank you so much. That was very helpful, Dr. Amy. Dr. Marin, let's talk a bit about more towards functional medicine and how it relates to hypothyroidism, and how can functional medicine help in hypothyroidism. And have you seen patients being able to reduce the dosage of their medications or stop their medications altogether after functional medicine treatment?
So I'll start with the last part of your question. And I don't think it's very easy to come off of thyroid medication. In general, my goal is always to optimize somebody's medication. And what I generally see after the course of a functional medicine treatment plan, once I've been working with patients for a long time, is they start converting T4 to T3 better. So some of what I do different in functional medicine is test free T3. And that is not necessarily a test that many thyroid doctors or endocrinologists will use. I find it clinically very helpful. But what I find is that, there's a lot of patients who feel better on some amount of T3 or natural desiccated thyroid. Usually if they feel better on natural desiccated thyroid, it's because they just need that little bit of T3. And, I'm pretty conservative with it when I use it, but it can make a big difference for people. And so anyways, the answer to your question is I do think that people can halt the progression of Hashimoto's, which will then prevent them from having to continually increase their thyroid medication over time. But once there has been gland destruction, it's hard to get that back. It's not like we can go back and get that thyroid function to return. And so I think generally people are better off using thyroid hormone as long as they're comfortable doing it and it's prescribed appropriately. So in functional medicine, really my sort of outlook is like, what is the root cause? Like why does somebody have hypothyroidism in the first place? And at a, very top level kind of view, I'm thinking about toxins, infections, and allergens. And so some of the big ones that go into that with thyroid is, Hashimoto's. So if somebody has autoimmune disease, there's really a triad there that I'm addressing for Hashimoto's. Number one is a genetic predisposition that I can't do much about. But number two is an environmental trigger. I can do a lot about that. And I can do a lot about number three with it, which is intestinal hyperpermeability. So my focus is very much on gut health when I'm working with a patient who has Hashimoto's because of the intestinal hyperpermeability piece. I mean, essentially with autoimmune disease, that's, you just have to consider that connection. So, it depends on the root cause. Sometimes, people have hypothyroidism without Hashimoto's, and we have to sort of look at why. Does it have something to do with iodine deficiency? I mean, that is a complicated kind of topic. Iodine is. Too much is a problem. Too little is also a problem. Does it have to do with toxins? I mean, I really think environmental toxins play a huge role in hypothyroidism. So that's usually, most of what I'm kind of working on with patients. And was there a part of your question that I missed?
I think, what I wanted to know how it relates to gut health. So basically, if you could expand on the intestinal permeability part of it.
Yeah, so the gut health piece is very interesting, I think, with the thyroid gut connection, because the thyroid influences the gut a lot. So it becomes a vicious cycle. So hypothyroidism can be a huge setup for small intestine bacterial overgrowth. We know that a lot of patients with hypothyroidism have constipation, but it just speaks to that, thyroid controls a lot of our the metabolism of our gut viscera, like the motility and the digestive enzyme production. And without that working optimally, we're set up for gut infections. So then there's this vicious cycle, because if we have a gut infection, that generally causes decreased absorption of very important nutrients that we need for our thyroid to function well. Things like selenium and zinc and iron and some of the B vitamins and vitamin A. There is also a correlation between the conversion between T4 and T3 and gut health and autoimmunity. I talked about the intestinal hyperpermeability piece.
Right. Okay, great. Thank you so much for that answer. Dr. Marin, my next question is in regards to women who are going through IVF and planning embryo transfer. So what is the optimal or desired range for T3, T4, and TSH to have if someone is planning an embryo transfer? And is there a standard? Does it vary from person to person? And how much time does it need to, push these levels to the optimal range? I'm sorry, it is a three-part question. I also want to ask you, how do you manage the antibody levels for someone who is preparing for a transfer?
Okay. So I think with regards to TSH, free T4 and free T3, if somebody is not pregnant, I'm testing those levels. If they're not on medication, well, whether they are or not, I mean, a TSH I would like to see close to 1. Based on the literature and the guidelines from the American Thyroid Association and the American Academy of Clinical Endocrinologists, TSH should be less than 2.5 when you're trying to conceive, whether or not you're attempting IVF or just trying to conceive naturally. So of note, when you look at your thyroid labs, the upper limit of normal is 4.5. So it will not be flagged as abnormal. And you have to know, if you're trying to conceive, abnormal is above 2.5. So trying to get that TSH around 1. And I like to see free T4 and free T3 in the upper range of normal. So I like to see free T4 around 1.1 to 1.3. And I like to see free T3 between 3.2 and 3.8.
Mm-hmm. Okay.
So in terms of medication dose, there is a standard dose based on weight. So you could do weight, you could start with weight-based dosing. And I usually start with a synthetic T4 medication in my patients who are trying to conceive or going through fertility treatments, just because it makes it a lot easier. And I actually prefer that to natural desiccated thyroid. Many of my colleagues use natural desiccated thyroid like Armour. I'm not totally opposed to that, but I would prefer to use the synthetic T4. My favorite is actually Convalescent, which is just a name brand of levothyroxine. So you can start with weight-based dosing at 1.6 micrograms per kilogram of body weight. So, it depends on somebody's weight, but that will give you kind of a starting point. And then I check labs. And when I'm checking labs for somebody who is just on Convalescent or levothyroxine, I check them before they take their medication. And if I see that their T3 is still really low, that's when I will consider using something like Cytomel, which is a synthetic T3 medication. I just use it, conservatively and try to titrate up to a dose where their T3 goes about 3.5 or so, somewhere in that range. Let's see, what was the other part of your medication or your question? I've lost track.
It was the antibody levels. So we want to reduce the antibody levels as well, right?
So that takes time. There are definitely some tricks. One of them is low dose naltrexone, which is actually safe to use in fertility and safe to use during pregnancy. So low dose naltrexone is kind of like an easy trick. There are also some supplements. In fact, selenium supplementation has been shown to decrease antibody levels, but you don't want to do too much too long. So I'd do that with your doctor's kind of guidance. And overall, like I say, it takes time because with the functional medicine kind of approach, I'm really working gut health and environment, and they don't, these things don't happen overnight. But I do see those antibodies, like most of my patients, I follow every 3 months for their antibodies. And if I have a good year with them, we can get their antibodies from 300 to let's say 250 to 200 to 180 to 170, so we see this progression and a downward trend, which totally correlates with our clinical improvement. But decreasing the antibodies can take time. And sometimes, obviously, if somebody's, trying to conceive, they don't necessarily have that time always.
Right. So do you wait for that patient or?
It just depends. I mean, if somebody, I've been there, like sometimes you're like, I want to have a baby. I don't want to have a baby in a year from now. I want to have a baby now. We just, I think the most important thing is if you're in that position and you have thyroid antibodies, that you're monitoring your thyroid function, whether or not you're on thyroid medication very closely, and whether or not you have normal thyroid function and you have positive antibodies, you've got to follow that every 4 weeks.
Right. All right. Thank you. I know it is a bargain. I mean, if you go ahead with embryo transfer and then you miscarry, it's again a loss.
Yes, totally. And that's why, I'm pretty, when it comes to fertility and embryo transfer, I think using levothyroxine or Synthroid or Convalescent, it's such a low risk with a potentially profound benefit.
Definitely.
That I just think the benefits far outweigh risks for most people.
Right. Thank you. Thank you for that great explanation. And so my next question is about your, it's a totally different topic and about something that you mentioned about the dental implants. So I have read that dental x-rays are the most common source of radiation to the thyroid, and it affects the thyroid gland. So it'd be great if you could talk a bit about how dental implants affect the development of hypothyroidism and otherwise how it affects our thyroid glands.
Yeah, I think dental issues are really interesting when it comes to health, and I take oral health very seriously, having come from a place of root canals and implants and a lot of other procedures, which were sort of the start of my own health issues. So take your dental care very seriously. I mean, we know that gum disease and a lot of these things are even linked with preterm labor and other pregnancy complications. But anyways, I digress. In terms of dental x-rays, prior to 1970, we used to do dental x-rays without a shield in front of the neck. Mm-hmm. And a history of head and neck radiation is a risk factor for hypothyroidism and thyroid cancer. That said, currently, our dental x-rays, we use a shield, and we also have newer, more modern machines, which expose us to lower levels of radiation. So I personally do not, my suggestions are usually to get your routine dental x-rays, as long as obviously they're using a shield and protection. People like dental hygienists, obviously might be at higher risk because they're exposed to that kind of thing. But I'm thinking about what are the low dose daily exposures we get versus the low dose exposure we get once every 6 months to a year when we get a dental x-ray. Mm-hmm. That said, head and neck CT exposes us to a whole CAT scan, exposes us to a whole lot more radiation than x-ray. But it's just like risk benefit. Sometimes we have to do that to kind of investigate other issues, but just kind of be aware that it is a risk factor and it does add up over time.
Right. And it's funny, my relationship with, going to my dentist and hypothyroidism is that I was diagnosed at my dentist.
Because they felt your thyroid.
Yes. So I went there in my teenage for braces, and then that's how they got to, they just asked my father to go to see a dentist. So, all right.
That's interesting.
That we should be careful about, all the dental fillings that we are getting.
So the dental fillings is like a whole other story. And this was just a recent, literally I think exactly 1 month ago at the end of September, 2020, the FDA came out and said people who have mercury amalgams who are considered high risk are those who are trying to conceive, those who are pregnant, those who are breastfeeding, and patients under 6 years old, and some people with neurological complications. But in the community of people who are trying to conceive, that's kind of a big deal. So of note, if you're pregnant or nursing, now is not the time to remove these amalgams from your mouth. Mm-hmm. There's a certifying body who has official recommendations related to that. So don't run to the dentist and get amalgams out when you're pregnant or nursing.
Right. All right. Thank you so much, Dr. Marin, Dr. Amy. I think it's time to bring in our patient advocate, Michelle DeMarco Amato now. Michelle, welcome to the show. Just a brief background about Michelle. She's the founder of Chronic Confidence Academy, a mentoring program designed to help women with PCOS and Hashimoto's. In addition to PCOS and Hashimoto's, she has had other autoimmune illnesses, and starting with the diagnosis of diabetes type 1 at age 7. And she lost 80 pounds of stubborn weight and got herself to a place of balance. So Michelle, tell us a little bit about your story and then go ahead and ask your questions.
Awesome. Thank you so much. So, hi, everyone. My name is Michelle DeMarco Amato. You probably know me as Girl with the Fake Red Hair on Instagram. And I'm so excited to be here. So I get asked how I did it all the time. And it's not a simple or a quick answer. It took a long time. But the one thing I can say is, in addition to the food, the sleep, the gut health, all of the other facets, the mindset portion is what made the difference. I had been just doing diet after diet for a long time, trying to just figure out how something could help. And it's when I stopped focusing on just the weight loss and I started focusing on doing things that generally help me feel better every day. Feeling like if I'm stuck in this body, then so be it. I at least want to enjoy my life in it. And that's when the weight started coming off, was when I was more focused on feeling better and longevity than I was on getting to a certain size. So it's not a very, direct answer, but finding out what I particularly needed and what was a sustainable lifestyle for me, and then dealing with the mindset side of things to make those changes and have them stick, I think is definitely the difference. So I'm really, really excited to ask you guys the next questions.
Please go ahead.
Good to go? This is my first time doing this, by the way. And you guys, I follow you on Instagram, so I'm a little bit starstruck. But, okay. So, Dr. Marin, what's your opinion on stress in our culture and its effect on the female body, particularly?
Yeah, I think we live with a lot of high-grade chronic stress, and especially women, because we're asked to do a lot of things, especially with COVID, because we're homeschooling and we're working and we're doing all the things. So I think of stress really as like the straw that breaks the camel's back with a lot of people when I think about health and disease. I think it's not like the cause of hypothyroidism, but it is like the straw that breaks the camel's back. And when we're talking about hypothyroidism and other hormonal kind of issues, it really impacts our HPA axis. And that just refers to our HP is the hypothalamus and the pituitary. These are in our brain, and they send out signals to the rest of our body. A is adrenals, which produce cortisol. And we need that cortisol if we're getting chased by a lion. But if we have it chronically elevated, it almost becomes something that people don't even realize that they are dealing with. It's just like this chronic, it's the new normal, And I think it definitely impacts women on multiple levels, emotionally, physically, sleep, all of the above. So I think it's a really big facet of disease that we have to address. But like I said, I don't think that it's like the cause of most people's kind of underlying issues.
Mm-hmm. Definitely. And Dr. Amy, if you had anything to add to that point, just how do you see stress affecting the female body, especially in this day and age?
Yeah, I mean, just exactly what Dr. Marin said, but for me and my patients, I've never seen people as stressed as they are right now. And I try and use language and thoughts to help build people up. And I try and, let's say, swap out the word stress and talk about it as excitement. Like, you're really excited to be here. I mean, it's obviously very stressful to come into my office. I know that sounds really weird, but it's people's stress that gets them to pick up the phone, to walk into the office, to take the medication. So there's a really good amount of stress that motivates people to get the job done and to keep asking questions and to advocate for themselves. So it's not all bad, but I try and help people see it as a positive thing, because it's helping them take care of the things that they need to take care of. But obviously, if you're having panic attacks, you're not able to sleep through the night, you're losing weight, that's a whole different story. And we have a team of people that we refer patients to, therapists, psychiatrists, acupuncture, you name it, mindfulness, and we support patients in that way. But the mental health aspect of being a fertility patient is one of the most important things to me. And it's one of the first things that I talk to all my patients about, and asking people about their stress levels is basically part of all my new patient intakes. So I'm glad you asked that question.
I love that. Excited to be here. I like that spin on it. So another question for you, Dr. Amy. Do women who have hypothyroidism tend to have a higher chance of getting PCOS? What kind of complexities do you see in managing symptoms in a patient who's dealing with both PCOS and hypothyroidism?
Great question. So in looking at does hypothyroidism cause PCOS, it doesn't seem to. I looked up in the literature, and there's like maybe one study that shows that women or girls with hypothyroidism had PCOS appearing ovaries. But if you look at who they were looking at girls, and a lot of girls have PCOS appearing ovaries. So I'm not sure you can say that hypothyroidism causes PCOS. However, on the flip side, vice versa, you can say that women with PCOS might have as much as a 3 times increased risk of having hypothyroidism. The exact connection as to why, I don't know that we clearly know, but it's probably genetic, and it's probably related to the fact that they are both also autoimmune diseases, and women who have one autoimmune disease could have another. It could also be related to a higher BMI and higher and insulin resistance. So they're all definitely connected. And as far as, how my patients feel about it, when my patients who have PCOS find out that they have something that they can balance. And I think about PCOS as something that you can heal and not just react to once you're ready to get pregnant. I feel like they are highly motivated to do what they need to do and to start medication, and they feel good that they have an explanation as to perhaps why they're having a hard time losing weight and all those sorts of things. So it's not necessarily a bad thing when you're diagnosed with it, because finally you have a solution and something that you can do that can help.
Absolutely. So, Dr. Marin, food is medicine, as it's been proven to be time and time again. But for some, access to nutritious foods it's very difficult. So what would be some vitamins that you would recommend at the bare necessity to be taking? And what do you find to be all hype?
Yeah, very important.
Yeah. So I think, if anybody's trying to conceive, a prenatal vitamin, I always recommend a prenatal that has methylated Bs and choline. And that's actually harder to find than you think. And when I'm talking about choline is sort of one of those that's really under-recognized, especially in prenatal. So you're looking for like 300 to 450 milligrams of choline in a prenatal. And if you look at the back of your bottle, if it even has choline, it probably has 50 milligrams. So those two things are big in a prenatal. And then a fish oil with high-dose DHA, we know can be very helpful as well to baby's brain development and maternal mood and brain health. And what other ones? I mean, for women who are trying to conceive, there's a whole other host of stuff, but CoQ10 is a huge one, like a higher dose CoQ10. And I know that Dr. Amy can chime in on this too, because she really directs her supplements specifically at fertility. Some of the other supplements, I mean, if you're really thinking basic and we're talking about fertility, it's like high quality prenatal with methylated Bs, a fish oil with high dose DHA, and CoQ10, especially if you're over age 35. Sometimes, vitamin D is a big one too. I will use, most of my patients need extra vitamin D. And so those are sort of the basics. If we go back to your last question about stress, there are certain medications or supplements rather we can use there. So ashwagandha is one of them. That's an adaptogenic herb. And so it's just supposed to help with the stress response. And there's been at least one small study showing that it improved T4 levels independent of thyroid medicine. I don't think it's a replacement for thyroid medicine, but I think it's worth a try for some people, as it might help. But I mean, those are kind of my basics, and it really depends on the patient. If I'm working on, gut health, I mean, there's a lot of things I use there, whether it's a probiotic or I like something called serum-derived immunoglobulins for patients working on gut health. So
I'm just curious, you mentioned ashwagandha, right? Doctors believe in a lot of Ayurvedic medications for healing hypothyroidism as well.
So I'm not really trained in Ayurveda. I'm curious and I think it's very interesting and open to it. But ashwagandha would probably be as far as I go, personally.
Thank you. Please go ahead, Michelle. Mm-hmm.
Awesome. So just a little bit of a bonus question for my own speculation. There's a lot of hype around different brands of inositol and D-Chiro and things like that.
Yeah.
Do you believe that those are necessary or hugely helpful?
So for somebody who has PCOS, I do like to use inositol. And for some people, when we're really working on sort of, preconception or infertility or just preparing to conceive, I think Chase Tree or Vitex can be very helpful for hormonal health. So those are probably two of the big ones I use. I mean, DHEA is another whole rabbit hole, and it depends. I mean, I really try to I don't have a protocol for everybody. It just really depends on what labs show. If somebody has PCOS, I'm going to approach it one way. If somebody's got, autoimmune thyroid, I'm going to approach it a different way, and just kind of take it one step at a time.
So, Dr. Marin, when someone's blood work shows that they're in the normal range, I heard you mentioning this before and I was getting all excited inside, but when someone's blood work is normal, but they're still experiencing a lot of aggressive symptoms, what is something you suggest?
Yeah, so it's different if you're trying to conceive or if you're not trying to conceive for most doctors. However, Dr. Amy knows about this because she's a fertility specialist. But I think most doctors, if you haven't seen a fertility doctor and you're trying to conceive and you're seeing your primary care doctor, they might not know that your TSH should be less than 2.5 when you're trying to conceive. So I think you just have to really be aware of that and advocate for yourself, ask for other labs. ask for your thyroid peroxidase and thyroglobulin antibodies to be checked, because most of the time those aren't checked. I can't tell you how many women I've seen who have been like, something's wrong. Something's wrong. I've been saying something's wrong for 10 years, and we check and we find that they have positive antibodies or even a positive ANA. So, you know, for me, I draw more labs than normal doctors. It's a risk benefit thing. But we find answers with labs. There can be really helpful. And so I think it just takes more investigation. So if you're still having symptoms and you have a normal TSH, first of all, make sure it's less than 2.5. If you're in the 2.5 to 4.5 or 5 range, that's still not going to be considered hypothyroid unless you're trying to conceive, but it depends on the physician. I will sometimes, you know, it's kind of subclinical hypothyroidism. It really depends on the definition you use. But I think, you know, a lot of people, it's like, we got to look further. We got to look at their free T4. And sometimes what you'll see is, you know, maybe TSH looks pretty normal, but free T4 is like 0.8. And that's technically normal, but it's at the way low end of normal. And people feel so much better with a little bit of thyroid medication. And it doesn't mean we're suppressing their thyroid or making them hyperthyroid. It's just a risk benefit thing. And to me, the benefits of a little bit of thyroid medication, you know, whether we're talking about fertility or blood sugar or high cholesterol, to me, they outweigh many of the risks when used judiciously.
Great. And this can be opened up for either of you doctors to answer, but when you have someone who is complaining of extreme fatigue, we all know physical activity is important for us, but sometimes it's a little bit of a battle to get there if you are so extremely fatigued. What is something you, either of you doctors would recommend to somebody who is saying that they want to be more physically active, they just feel they can't be?
Well, I'm sure I'll have a different answer than Dr. Amy on this one, because in functional medicine, we talk a lot about mitochondria. And that is one thing I think about with somebody who, you can have mitochondrial issues and you can also have thyroid issues. If we have properly replaced thyroid hormone and your levels are optimal and you still feel tired, we need to look elsewhere. So mitochondrial function, we produce ATP. It's like our big energy producers. And if our mitochondria aren't working optimally, we need to understand why. Toxins and heavy metals are a big trigger for that. And so we have to decrease the toxin load or decrease the heavy metal load, whichever, you know, whatever it might be. And then we have to give our mitochondria the nutrients they need to perform optimally. And these are things like CoQ10 and L-carnitine, alpha lipoic acid, some of the B vitamins. So that is one of my probably, like when somebody says they work out and they feel terrible the days after, I think about mitochondria and I say, well, don't push it. You need to be active, Tai Chi, yoga, whatever, do something where you're moving, walking, whatever it is. Everybody needs to move every day. But if, you know, doing Orange Theory Fitness makes you feel terrible, don't do that. Choose something more gentle until we can get you to a place of better health.
And then I'll just add along those lines. I take something called NAD, and it can help your mitochondrial health. And I literally slept 3 hours last night. I don't know that you can tell right now. Looking
No,
at me.
you can't at all.
I'm actually
Amazing.
85 years old. You can't tell that either. I feel like it's like a magic pill in a lot of ways. And I have a lot of my patients take it because it can also support egg quality too. But I think it can help with energy. It does have side effects. So, you know, you don't necessarily need a doctor to like prescribe it to you because you can get it online without the prescription of a doctor, but you should be careful about it. There are different doses. So some patients do better on lower doses. So if you're feeling like a spaz, you don't need to be like me every single day, sleeping 3 hours. No, I'm not recommending that at all.
I also take NAD.
Nice.
Just for the record, everybody's going to go take NAD.
I'm looking up as
I'm also 85.
Definitely adding that to my cart as soon as we're done here. So thank you guys so much. That's all the questions I have so far.
Thank you. Thank you, Michelle. And thank you, Dr. Amy, Dr. Marin. And thanks for letting us know about the magic pill. We will definitely go and search it out. So I'll move on to my next question for you guys. Dr. Amy, you can take this question. So I have been through 3 IVF cycles now and many embryo transfers. I just forget the count now, and have taken loads and loads of estrogen and progesterone pills and injections and whatnot. So I wonder how would it affect the progression of my hypothyroidism compared to someone who didn't take all these extra hormones.
So what I would say from my experience is that it can affect your thyroid function. And if you are my patient, and I would love to put you on a plane and have you fly here, but until that time, I would just monitor your thyroid function extremely closely. Just like Dr. Marin said, almost 2 to 4 weeks checking antibodies or checking levels. For me, it might almost be every 2 weeks, and then not doing a transfer until we know everything is really stable. But I'm not necessarily worried about any long-term effects on your thyroid from the hormones, especially if you're being well managed. So that's kind of my perspective on that.
All right. Okay. That gives me some peace to hear that.
Well, I'm going to actually just bring something up, and I'm actually curious, not to throw a monkey wrench into this, but I'm always very sensitive about the possible long-term effects of IVF treatment and things like cancer. And there has been a small suggestion, perhaps, that women who go through IVF might be at a slightly increased risk of thyroid cancer. In the last 13 years, I've had 3 patients who've had thyroid cancer. So I will qualify it and say you need to still see your doctor very regularly to make sure that we're not missing that.
Right. And then having these antibodies and having Hashimoto's as a new thing on your chart doesn't indicate that for sure, right?
No.
Definitely. Okay, cool. I'm good. All right. Thank you so much. So Dr. Marin, it will be good to know your perspective on this from a kind of a functional medicine point of view, and what precautions do you think should women undergoing IVF should take to protect their thyroid?
Yeah, so much. I mean, Dr. Amy is the expert on this one, but when you're taking fertility medication, it's sort of like when you get pregnant, you have a lot of hormones on board. It's going to change the way, basically it changes the proteins in our blood, binding globulins that affect the bioavailability of free hormones. And so that just means, taking a lot of hormones might affect your thyroid function. Monitor it really closely. If the fertility doctor says to check it every 2 weeks, I would for sure check it every 2 weeks. It can be complicated, like right in the middle of taking some of those medications. So it's good to have different data points. And I think it's great, if your doctor is comfortable checking a TSH, a free T4 at least, hopefully a free T3 also, I find that very helpful, but it's not every doctor's practice. But I mean, even if you look at the guidelines from the American Thyroid Association, they recommend checking every 4 weeks during IVF, and then just a really low threshold for treatment with thyroid medication, especially if you have Hashimoto's in this situation. Like, I mean, that you can consider treatment based on the guidelines. You can consider treatment levothyroxine with a normal TSH, like of 1, if you have thyroid antibodies, especially if there's a history of prior miscarriage.
Mm-hmm. All right. Thank you. Thank you. That helps. So I guess before closing, let's talk about COVID and how is it affecting our thyroid glands. I read somewhere that these thyroid glands, they have these ACE2 receptors on the surface of their cells, which kind of allows the COVID virus to get into our cells. And it is suspected that in severe cases, the virus is able to infiltrate the thyroid gland. So I'm just curious, how are you both noticing any changes or in symptoms in your patients with hypothyroidism as a result of this pandemic? And what do you suggest if someone with hypothyroidism gets positive test for COVID?
So from my perspective, I think I'll answer the question like this. First of all, thyroid disease, when people who have it, you're not immunocompromised by having it. It's an autoimmune condition. And I think there can be some confusion. So I'm not necessarily concerned about my patients who have hypothyroidism if they get COVID. I don't think that they are an at-risk group. What I do notice is a lot of people aren't sleeping very well right now. They have a lot of stress. And so when I'm doing my screening TSH, their TSH levels are really high. And I ask them, did you sleep last night? And they're like, no, I was really stressed out. And then I repeat it again after they get some sleep and their thyroid levels are normal. So I'm probably checking more, having to do some more repeat checks because of COVID. But what I'm also noticing, just related to all chronic medical problems right now is that people just aren't getting the care that they need and deserve. And people aren't getting refills on their prescriptions, and COVID can use as an excuse in a lot of these cases. So I just say, it's not COVID, it's go video. So make sure you find a practitioner that's going to help you advocate for yourself, use your voice, and get treatment. If you have a thyroid nodule, don't ignore it. Get the care that you need. You can do it without fear that you're going to get COVID. You can get really safe care right now. And I want everyone to go ahead and do that, especially pregnant women.
Sure. Thank you. Thank you. I'll quickly move in the interest of time to some of the listeners' questions that I have. Dr. Amy, I'll start with you. And I see that people have posted on Instagram and on other social media talking about hyperthyroidism. They want some inputs on hyperthyroidism. So can you tell us how hyperthyroidism affects fertility and IVF success?
Absolutely. So it can also affect the menstrual cycle. I think people forget, it takes two to tango, and it can also affect sperm counts, right? So every embryo is an egg cell and a sperm cell. And we usually are given the diagnosis of unexplained when the sperm is abnormal, but it could also be related to hyperthyroidism in sperm. It could be a cause for miscarriage and also for other pregnancy-related complications. So hyperthyroidism is also something that should be addressed and treated pre-pregnancy and during pregnancy and even after.
Sure. All right. So the next question, I guess we have sort of answered it, but I'll just read it out for you. My TSH is 5.3 and I have an egg retrieval planned in December to preserve fertility. Would that TSH levels impact the egg quality? And what is the diet you would recommend to bring down the TSH levels?
Do you want me to
Amy,
answer?
I'll let Amy, address that one.
So the way I think about it is going through an egg retrieval, it's a surgery. There's a lot on the line. Like fixing your thyroid, it's easy. So let's fix it. Is it going to affect your egg quality? I'm not so sure, but you're going to go through something that's invasive, really expensive, and really means a lot to you. I never want you to look back and say, like, why didn't I fix my TSH first? It'll get fixed, like I said, very, very quickly. So that's kind of how I would answer that question. And obviously repeat it, look at all the labs. I don't know that I would necessarily delay your treatment by months. I think that just seeing a specialist, getting started on treatment, even if it's like 2 weeks or a month before you start your egg retrieval cycle, that would be perfectly acceptable to me. And as far as diet to recommend to bring TSH levels down, I mean, I'm not one of those people that necessarily feels like we have as much control over our thyroid with diet. Obviously, diet in conjunction with medications is very helpful. And I know there are people that want to try diet first, and I totally support that. But at the end of the day, sometimes you need a little something to get your TSH level down.
Mm-hmm. Right.
Yeah, I would agree with that statement. I mean, obviously nutrition is important, but it's hard to move the needle on your thyroid with just food.
Right.
Or I don't want to say impossible, but.
Okay, thank you. The next question, I think we have already addressed it. Can hypothyroidism be cured, or does the person have to be on medication lifelong? So I think, Dr. Marin, you addressed that risk-benefit thing for thyroid medications, and I totally agree to that. So moving on to the next question is, what food is strictly avoided by those who have Hashimoto's and hypothyroidism, and what is allowed once in a while?
I personally am very strict about gluten. Probably gluten, then dairy, then sugar are kind of the main culprits for most people who have autoimmune thyroid disease. So Hashimoto's, or, if we're talking about Graves' disease, that's in the same sort of category as well. So gluten, I'd be really strict about. And it depends. Like for some people, they need to also be strict about dairy. And then, really trying to, I think, minimize or avoid refined sugars, and alcohol is a good idea for most people, but I don't think of it as like a something that you have to be perfect about. I think, with much of nutrition, I prescribe to the 80-20 rule. 80% of the time make some great choices. 20% of the time, you don't have to be perfect. Sometimes the stress of trying to achieve a perfect diet is more than it's worth. So.
Right. Okay. And I've read that some people or some nutritionists, they also ask you to avoid cabbage, cauliflower, spinach.
Yeah. So Goitrogens, I'm not really too worried about goitrogens, and I'm not really too worried. I mean, I don't, if somebody's eating soy every day and a lot of soy, there's,
and it can be
soy is, so and the literature is really actually supportive of soy for a lot of people, but I wouldn't do it as like an everyday kind of thing. And then goitrogens, if you're eating like raw kale and cabbage and like every single dish of your meal has like a heaping pile of goitrogens, I would probably cut back on that or try to like cook some of the foods. But I don't really think it's like a huge issue.
All right. Yeah, that's what I felt. I mean, if you're eating in once in a while or once a week, it should be fine, right? It should.
Yeah.
It doesn't
totally.
affect all kinds of hypothyroidism, right? If it is because of
I think most people really do fine with it. So again, unless they're eating like ridiculous amounts. So nobody's doing that.
All right. Thank you so much. Thank you so much, Dr. Amy, Dr. Marin. It was wonderful listening to you and all the information you shared with us today and learning how we can better manage the symptoms of our hypothyroidism and Hashimoto's disease. And I'm sure this talk will be very helpful for women trying to conceive or planning for an embryo transfer and will help them be better prepared. And we wish them all the luck that they be successful in their journey to family building. So thank you very much to both of you for finding time to educate us today. And Michelle, thank you for joining the panel today and help us guide the discussion with your very insightful questions. We will make this talk available on CureTalks.com as well on CureTalks YouTube channel. And please visit our website, CureTalks.com, for details on upcoming talk. Until then, thank you everybody and have a great day and stay safe.